Okay, we are ready to present. This is our presentation on the pain neuromatrix by myself, Carrie Brody, and Jessica Keller. As all of you are familiar with the gate control theory of pain, which was published in 1965. This theory has been part of our foundational knowledge since taking our first modalities class, but many of us might be a little rusty in explaining it. The importance of the discovery of the gate control theory was that it not only stimulated a rash of new research, but it also highlighted the dynamic role of the brain in the pain process. One of its most valuable contributions was that of the emphasis of the central nervous system as an essential component in the pain system. Prior to this, peripheral factors were thought to be the primary component of pain. These developments motivated researchers to try to understand brain function in relation to pain, the result being a pain neuromatrix. This may or may not be a new term to most of you. It was new to me before we started this presentation. In the following slides, we will go into greater detail about this theory and how it has impacted the knowledge surrounding acute and chronic pain. Pain has been linked to injury for some time. There is a well-documented case of a young girl in 1950 who was diagnosed with congenital analgesia. She was intelligent and displayed normal behaviors, but had absolutely no reaction to pain. In fact, one time she actually bit off the tip of her tongue when she was eating. She also gave herself a third-degree burn by sitting on a hot radiator when she looked out the window. Her responses to pain were tested with noxious stimuli, many of which would be inhumane today, and produced no changes in her blood pressure, heart rate, and respiration. This patient also developed severe medical problems and injuries to her joints because she did not avoid certain postures or shift her body weight to prevent inflammation of the joints. Most of us shift our weight when standing in one position becomes too uncomfortable, but she lacked the ability to sense this discomfort. Unfortunately, her story does not have a happy ending. She passed away at the age of 29 from several massive infections. Upon further examination, her nervous system did not reveal any abnormalities. Her nerve endings and receptors were all normal, but clearly there was a dysfunction somewhere else in the system. Congenital analgesia is extremely rare, but episodic analgesia, in contrast, has been experienced by most of us one time or another. If you have ever cut yourself and not felt pain for minutes or sometimes hours following the injury, you have experienced episodic analgesia. Extreme cases of this are demonstrated in wars when soldiers are hospitalized with amputations and severe wounds but do not complain of any pain. Eventually, all of these cases will experience pain and it will be localized to the injury. But why isn't pain present initially, even if the person is focused on the injury and not suffering from shock? Another mystery to the pain process is phantom limb pain. I am unsure how this experiment was conducted, but several segments of a spinal cord were removed to prevent sensory information from traveling from the pelvis and legs to the brain. This surprisingly did not result in removal of intense pain from half the body. Even more amazing are cases of individuals born without limbs, yet they experience painful phantom limbs. These examples make it very clear that pain is not just about a pathway to the brain. The experience of pain is also genetically built into the brain. The varieties of pain experience show that there are many components involved in the process. Placebos are yet another tool to show the effect of anxiety on pain. It is normally assumed that suggestion itself is responsible for the reduction in pain by placebos. It also seems that a reduction in anxiety about pain occurs when patients are given a placebo because it makes them believe that something is being done to eliminate their pain. Several studies have shown that placebos are more effective for severe pain than mild pain, and also more effective in people who are under great stress and anxiety. The link between pain and injury has always seemed so obvious that it was easy to dismiss other causes of pain. Although there is an undeniable relationship between pain and physical damage, there are also many instances where this theory is not accurate, as demonstrated by the previous examples. Before we talk about the neuromatrix, we must talk about a matrix and what it means. According to dictionary.com, a matrix is something which constitutes the place or point from which something else originates, takes form, or develops. In this sense, Melzack has defined the neuromatrix, not the stimulus, peripheral nerves, or brain center, as the origin of the neurosignature, and this neurosignature originates and takes form in the neuromatrix. We will discuss these terms a little bit more in a few minutes. Another definition by Melzack is a mold or dye that leaves an imprint on something else. In this sense, the neuromatrix casts its distinctive signature on all inputs that flow through it. And last, it is an array of circuit elements. The neuromatrix is an array of neurons genetically programmed to perform the special function of producing a signature pattern. What is the pain neuromatrix? According to Melzack, it is a genetically built-in matrix of neurons for the whole body, which produces characteristic nerve impulse patterns for the body and the myriad of somatosensory qualities that we feel. It is basically a large, widespread network of neurons with loops connecting the thalamus and cortex, and also connecting the cortex to the limbic system. Just a brief anatomy overview, the thalamus is located on top of the brainstem. It is like a switchboard which receives sensory signals and relays them to the cortex. The cortex is the outermost sheet of neural tissue on the cerebrum and plays a role in memory, attention, awareness, language, and consciousness. The limbic system deals with the formation of memories. In the neuromatrix, the spatial distributions and synaptic links are initially determined genetically and are later sculpted by the sensory inputs. You can see from this definition that there are many components to the pain process. Let's talk about the neurosignature. As I mentioned before, it originates and takes form in the neuromatrix. It is a characteristic pattern produced by synaptic connections in the neuromatrix. All inputs from the body undergo cyclical processing and synthesis so that characteristic patterns are impressed on them. This neurosignature is projected to the sentient neural hub of the brain, where it is converted to a changing stream of awareness. It is a continuous outflow from the body self neuromatrix, which also activates neural networks to produce movement. Okay, we've talked about a lot of big terms, so what does this all mean? And how can we explain it? Well, basically, the brain is made up of a widespread network of neurons that processes information from many different inputs and produces a whole body sense of self. The brain processes are normally activated and modulated by inputs from the body, but they can also act in the absence of these inputs and instead on the experience and memory of the inputs. Pain is a multidimensional experience. The body is felt as a unity, and there are many factors involved in the pain experience, such as stress, culture, sensation threshold, past experiences, situations, attention, and anxiety. Neuroplasticity is another term which, according to Puretic and Demarin, the nervous system is constantly changing due to the development of new neuron connections and the response to new stimulation or new environments. Therefore, the brain can adapt to disease and disability. Neuroplasticity plays a large role in chronic pain by inhibiting the filtering ability of central sensory neurons, resulting in wrong interpretation of noxious stimuli. Continuous and intense stimuli can lead to these neuroplastic changes in the brain and spinal cord, resulting in chronic conditions such as fibromyalgia. If the body is felt as a unity, how can we relate pain and the body?
This is a great diagram of pain in the body. It's a good visual reference for the components and the input. As you see, inputs are sent from the body self, and we'll talk more about that in just a little bit, and are processed in the context of cognitive, sensory, and affective processes of the body. And then they're sent out to be felt. This, for me, is a little bit better picture, maybe because it has color, but it's easier for me to see that the impulse travels to the brain, is processed by many different parts, and then is sent back out to be felt. So let's take a look at some of these areas. Think about it for a minute. One day you were in clinic, you had a headache, you didn't feel great, but you still went in. You went and you treated a patient. And while you were treating the patient, for some reason you didn't notice your head hurting anymore. But then you got done treating the patient, and all of a sudden your head started bothering you again. You were distracted, and part of the way that you were processing that pain in the cognitive set allowed the pain to not be the primary thought right then. So your attention was diminished. Now take a look under context. What about your beliefs about pain? Is pain positive? Is pain negative? Does that change how you react to it in some way? Is it okay that you're hurt, or that you just don't feel good? And some of the ways that we believe pain and some of the ways that we expect pain to be taken care of with certain medications or certain techniques or processes change the way that we think about pain and how significant it is in our lives. Mood, depression, anxiety, we've all seen that people who are depressed or aren't feeling well already, have a high level of anxiety, also experience pain more acutely. And then with the chemical aspect of things, the body not only processes pain based on context and cognitive factors, but on whatever chemicals are floating around in your blood. And we know that our mood affects our neurochemicals, and that in addition affects pain. So let's take a look at some of the research. Melzack is a major foundational player in the pain discussion. In his article, From the Gate to the Neuromatrix, he discusses his ideas on how the body processes the pain signal. So the first one is that what we normally feel is subserved by the same neural processes in the brain. Each time we feel pain, the same parts of the brain are involved. Typically, the feeling is activated from the body, but other things can activate feeling as well. Number two, all of the qualities we normally feel from the body are also felt in the absence of input from the body. Think of it this way. Have you ever had a hammer and almost smashed your thumb with it, and you jerk your thumb back and you shake it? Sometimes you even kind of holler about it, or some of you might swear about it. And you didn't actually hit your thumb, but you felt like you hit your thumb. And so it's one of those situations where you never really had the stimulus, you never really had the hammer crash down on your thumb, but because you anticipated that it would be really unfortunate if you did, your body reacted just like that's actually what had happened. The third point that he makes in this article is that things that happen to your body are happening to you. So how you feel about those things happening determine the amount of pain that you will feel. And that's when we talk a lot about the body self. And then the fourth thing is the brain processes that underlie the self are built in but can be altered by experience. Carrie mentioned that a little bit ago. When we're born, our brains are designed to process pain a specific way, but over time and based on different experiences, that changes. Melzak did another article in 2001 called Pain and the Neuromatrix in the Brain. And in this one, he helps us figure out a little more deeply how the neuromatrix affects chronic pain. It says output patterns of the body self neuromatrix activate perceptual, homeostatic, and behavioral programs after injury, pathology, or chronic stress. Pain then is produced by the output of widely distributed neural networks in the brain rather than directly by sensory input evoked by injury, inflammation, or pathology. The output pattern is determined by multiple influences, of which the somatic sensory input is only part, and that converges on the neuromatrix itself. In another study done by Schlethrin and Berkling in 2008, they reported that a perpetual state of stress actually causes the body to feel more pain. So Melzak talks about this conceptual nervous system, or how he thinks that this probably works. He talks about the neuromatrix receives pain and then kind of bounces that signal all over the brain to each part responsible for processing the factors of pain. That then produces a neurosignature. And that neurosignature is essentially a plan for how the body will handle the pain. The neurosignature is then converted to a state of awareness in the sentient neural hub, and then passed back out to the body to be dealt with. It's one of those processes where you're walking on the beach, you step on a sharp rock, the foot sends a signal to the brain that says, hey, that's sharp. The brain decides what it thinks and feels about that information, decides that it's against standing on the rock, and then tells the foot to shift its weight off of it. Anytime the body feels pain, it works really hard to fix it. So when your body is injured, the injury doesn't just produce pain, it produces stress in the body, and that stress disrupts the homeostasis. Disruption of the homeostasis of the body makes the body activate neural, hormonal, and behavioral activities to restore the body. So in short, the neuromatrix, as a result of a homeostasis regulation patterns that have failed, produces the destructive conditions that may give rise to many chronic pain patient issues that so far have been resistant to treatment, developed primarily to manage pain that are triggered by sensory inputs. And this is one of the major theories of how chronic pain works.
Continuing with the research, another significant researcher was Derbyshire, who wrote an article called Exploring the Pain Neuromatrix. In this article, he discusses the usefulness of functional imaging to explain what occurs in different regions of the brain when the body is faced with noxious stimuli. He concludes that there is a biopsychosocial model of pain in which each view pain as a mixture of cognition, affect, and sensation mediated through widespread brain regions. He also agrees with Melzak's idea of a neuromatrix, which explains pain in terms of a combination of these three factors I just mentioned. But he also states that more research is needed to explain why certain regions of the brain perform certain functions and how the systems might be dysfunctional in some patients. There isn't any imaging to support that yet. Continuing in his article, he goes into depth about the different regions of the brain and spends a lot of time discussing one region, the anterior cingulate cortex. This is the attentional system. It is further subdivided into a perigenual cingulate and mid-cingulate. The first one, perigenual, processes feelings of fear and other emotional responses, also recalling sad events. The mid-cingulate area is involved in executive functions such as response selection during divided attention tasks. The cingulate cortex as a whole has the necessary properties to be a key area in attention, discrimination, avoidance, and effect. It also interconnects with regions engaging inhibition and autonomic responses to pain. Another researcher, Mosley, wrote a pain neuromatrix approach to patients with chronic pain. Here, chronic pain management is evaluated in terms of the pain neuromatrix. He treats chronic pain by lessening the input to the neuromatrix without activating the output. Pain and changes in motor control are considered two dimensions of a multidimensional output of the pain neuromatrix. Here, Mosley states that pain is produced by the brain when it perceives that danger to body tissues exists. It is a multiple system output, not just an unpleasant sensory and emotional experience. They also found that the notion of pain as a reliable informant of what is actually happening to the tissues is no longer accurate. Each dimension of pain is consistent with an immediate relevance to survival. Mosley also talks about the anterior cingulate cortex and says that it establishes emotional impact of pain and coordinates the body's response to pain. Some cortical areas of the brain are more involved than others during pain. The anterior cingulate cortex is responsible for asking the question, what should I do now when the body is faced with pain? It is also chronically active in chronic pain patients and becomes hypersensitive. Mosley introduces the concept of the virtual body. It provides a common platform from which experiential and motoric dimensions of pain can be launched. When pain persists, the nociceptive system and the virtual body undergo profound changes, which increase sensitivity to noxious stimuli as well as non-noxious, and corrupt the integrity of motor output. This term virtual body is also similar to the body self proposed by Melzack. The goal of Mosley's clinical approach is to reduce the sensitivity and activity of the pain neuromatrix by reducing the threat. They propose two ways to do this, reducing the threat and activating the patient's pain neuromatrix. Three main effects occur after injury and with chronic pain. First, there is a reduction in tissue tolerance by virtue of altered tissue properties, deconditioning, and deuse. There's also a reduction in the activation threshold of the peripheral nociceptors, such that the integrity of the tissue-based protective mechanisms is maintained. And third, there is an increase and diversification of threatening input, which causes the pain neuromatrix to be activated at lower levels than it normally would. Motor strategies can provide important insights into what inputs are likely to activate the pain neuromatrix. According to Mosley, reducing the threat is accomplished by educating the patient about human physiology as a way of altering beliefs and attitudes about the meaning of pain. Once the patient feels that they have power over their pain, it is supposed to help reduce that threat. How do we treat portions of the patient's pain neuromatrix without activating the entire thing? Mosley says you can do this by determining what level of nociceptive input can occur without activation through motor and functional basis.
So as we continue to study the neuromatrix, we look at an article written by Tracy in 2007 called The Cerebral Signature for Pain Perception and Its Modulation. And we start to see that people are simplifying Melzack's theory, and they're also kind of starting to step away from it a little bit. Not much, just a little bit. So they're now more commonly calling this the pain matrix instead of the neuromatrix. And simplistically, it's thought of as having a lateral sensory discriminatory and medial affective cognitive evaluative neuroanatomical components. Also, they believe that, or Tracy believes that, different pain regions play more or less active roles depending on the precise interplay of the factors involved. So, depending on what else is happening in the body, parts of the brain are sometimes otherwise occupied and they give less input. And we talked about that a little bit earlier. Also, Tracy noted that it was difficult to specifically define what structures should be thought of as included in the pain matrix. So, for the pain matrix to retain its utility, it's needed to be viewed not as a standalone entity, but rather as a substrate that is significantly and actively modulated by a variety of brain regions, and that its interaction in large part determines the pain experience.
Another very important research on the Neuromatrix is Melzak's book, The Challenge of Pain. It's a very interesting book where he attempts to give the reader a better understanding of the pain process in the hopes that it will lead to greater relief of the pain suffered by so many people. We already discussed some of pain in relation to injury, but there are also many other examples that he cites in the book, such as pain that occurs without injury. This is seen in something such as a tension headache, where there's no real physical damage or injury, but there's definitely significant pain. Another example would be pain disproportionate to the severity of injury. One example he gives is passing a kidney stone. Many of you would say this is extremely painful, but if you actually look at the mechanism of this, it shouldn't be because it occurs in an area that is not highly innervated. We also see this pain disproportionate to the severity of injury in several of our patients. We may have similar injuries, but very different reactions from the patient. These cases provide more evidence about the highly variable and unpredictable link between pain and injury. We can also find information about physiology of pain in many textbooks. And Melzak goes through a more descriptive approach to this as well in his book. Here he explains the pain process in acute injuries and also offers an alternative function of C fibers in pain conduction. He suggests that they may also play a role in shaping the central nervous system to respond to the dramatic necessity of gross injury and may also respond to minor abnormalities. Last, pain theories have progressed from the traditional specificity theory to the gate control theory and more recently to the multidimensional neuromatrix and are now continuing to evolve from there. What are we using to control pain? In some cases, we're effective, and in others, we really aren't. Drugs have been studied and used to an extent, also sensory modulation techniques, and psychological procedures. Here, Melzak goes into some more descriptive procedures that have been used on pain. One, destroying peripheral nerves. A procedure called a rhizotomy attempts to destroy the sensory roots, leaving movement intact. The ganglion, which connects the cell bodies of the sensory nerve, is separated from the spinal cord so that the nerves degenerate and are permanently lost. This is not a good surgical outcome. Aside from it being a painful surgical procedure, it is not permanent and also brings about total anesthesia rather than just a decrease in pain. Another option, a sympathectomy, the ganglia are injected with a destructive fluid. This blocks the activity of the sympathetic nervous system and all pain is decreased. Again, a very invasive option. Relaxation is another technique which has been used and studied extensively. Relaxation is supposed to decrease the activity of the sympathetic and motor nervous systems. We are constantly prepared for fight or flight situations, and the body is always under stress. In a study done by Yamaguchi and others in 2000, they found that relaxation had beneficial biomedical effects in patients with persistent neuropathic pain. In another study by Lazar and others, MRI imaging showed slow changes in neural activity with meditation, which is consistent with the subtle changes that are reported subjectively by the patients. Meditation is a slow process, so it takes a while for those changes to take effect, and this was noted in the MRI. Another option is hypnosis, although not a very successful. Only about 15% of the population can be hypnotized easily, and results from hypnosis haven't been much better than a placebo effect. Last, acupuncture is a use of meridians, which are channels in the body that connect the yin and yang, or the spirit and the blood. And this has been used for many, many years as an effort to control pain and has been very successful.
So since there are lots of different influences that make up the pain that we feel, it's reasonable that it would require multiple approaches to address the pain. Things like past experience, culture, trauma, sensory input, and physical condition all work together, plus some other things that we've already talked about, neurochemical things and distraction and whether you're depressed or anxious, or all of those things work together. And so it's going to require multiple approaches, not just necessarily fixing the problem if there is one, but also looking at some of these other things as well. Some current interventions, or possible interventions, is mindfulness training. That was talked about a lot by Kabat-Zinn and others, and we're reading a book on it. So we kind of understand that when meditation has had a lot of useful information published about it. A study by Ormy Johnson and others concluded that the use of meditation showed a 40 to 50% decrease in voxels, which is a three-dimensional form of measurement, of the thalamus when responding to pain caused by a hot object placed on the skin. Participants in the study had to learn the transcendental meditation and practice for 5 months before they were allowed to be a part of that study. The other thing that we're finding, though, is that some of the things that we have found to be effective or were demonstrated that were effective for us this summer don't have a lot of research available to us. Things like tapping, the emotional freedom techniques, PRRT, John Imes and company working on that, TREs, the trauma releasing exercises. Those are kind of lacking in the research department. AAT is another one. Dr. Skayer did quite a long presentation on AAT. It's available on their website. But essentially, AAT is a manual technique that provides sensory input to the amygdala in a safe environment that extinguishes the perpetual arousal state that is a source of chronic pain and physical dysfunction. We have overwhelming anecdotal evidence on this and on some of the other ones that we mentioned, but they lack substantial research. The idea behind this treatment is that decreasing upregulation by breaking the cycle of perpetual arousal will allow the body to return to homeostasis, and that will allow us to more effectively relieve pain.
All right, so this brings us to future research in this area, and hopefully we've explained it well enough that you can think of some possible research that can be done. Some of the things that we came up with, a study was done by Amoygu, I hope I'm pronouncing that correctly, in 2006, where they had the development of the law of pain, another pain theory. They used this to classify all pain, acute or chronic, and state that the origin of all pain is inflammation and the inflammatory response. A variety of biochemical mediators, cytokines, neuropeptides, growth factors, and neurotransmitters are present, not just the typical prostaglandin. They say that inflammation can exist without structural damage, but it can also cause structural damage. So one question we had is pain really caused by the inflammatory response and a multitude of these biochemical mediators? Another possible question, what are the genetic contributions to stress and their role in chronic pain? We know that genetics and experience and history play a big role in how we feel about pain and how we handle stress. So looking at some of those contributions. Third, a study by Poghouse looked at cerebral activation during pain anticipation and found that the expectation of pain activated specific regions in the brain. So, can we actually treat this anticipation of pain in an effort to eliminate chronic pain? Number four, what are the effects of whole mind, body, spirit interventions on chronic pain? There are several ways to look at this. A study by Trout used the Neuromatrix theory for women in labor and to advocate the use of midwives to look at different components in what causes pain during labor, such as previous experiences, and how they could treat that. Number five, are pain clinics the answer to successful treatment of complex chronic pain? Melzack talked about having one concerted effort into the cause of pain and utilizing multiple theories. And this would all take place in one pain clinic. So is this the answer to successful treatment of chronic pain?
So a few other questions that we had are, what are the effects of emotional freedom techniques, or AAT, in relieving acute pain? We know that it's rumored to work well on chronic pain, but we're kind of curious as to whether or not it would work on acute pain. Number 7, what is the psychobiological mechanism of meditation? So how does meditation affect a person's overall well-being? How does it affect the function of the brain? How do those work together to control pain? We know there is an effect, but we would like to know why. Number 8, how much training in meditation is required for a patient to be able to control their own pain for medical procedures? How good do you need to be at meditation? Will pain draw an inexperienced patient out of meditation? And how effective is it? Does it depend on a patient's ability? Number 9, does PRRT eliminate the anticipation associated with previous painful stimuli? Kind of what Carrie was talking about earlier. If pain is stored as procedural memory, is PRRT reprogramming that response? And then number 10, how do specific regions of the brain perform certain functions in the presence of noxious stimuli? Specifically mapping each section to try to determine the overall effect it has on the feeling of pain and helping to find which parts of the brain to include in the pain neuromatrix. Thanks so much for letting us share what we've learned with you. We've listed our references here for your review. We hope you have enjoyed this and that you think of lots of really great questions to ask us.